whoops, sorry, hang on. Okay, now, the next category that we're going to talk about are diseases of the respiratory system. Diseases of the respiratory system, important to recognize first the structure of the respiratory system. Hang on, didn't we do respiratory system? A little help there. We didn't do respiratory system here? Confusing my classes? We did respiratory system. Okay, maybe not, because we were going to do respiratory system with viruses. Okay. Nobody's jumping up and down, right? Well, maybe we did. Okay. All right, so we'll start with respiratory system. First, to understand the disease processes of the respiratory system. I did it for one class this semester. It must not have been you. But in the respiratory system, very important to understand the structure of the respiratory system first. Again, those of you in AMP2 probably have a little advantage in the sense of understanding the structural anatomy of the respiratory system. Divided into two parts, an upper respiratory system and a lower respiratory system. The point of demarcation is typically at the level of the larynx, separating the upper respiratory organs from the lower respiratory organs. In the upper respiratory system, consisting of the nose, the throat, areas of the middle ear, the auditory canals, remember there is the external auditory meatus or canal that leads and runs, little small tubes run through the inner ear and actually come and open up, communicate with the posterior oropharynx. And so there's a little communication there, and because of that, infections that can infect the upper respiratory system, especially the pharynx, can migrate up those tubes and infect the ear as well. So ear infections would also be considered a part of upper respiratory infection. Lower respiratory infections layer or area below the level of the larynx. Tracheal, bronchial tubes, lungs, alveoli, where the air sacs lie at in the lungs, which exchange oxygen for CO2, can be significantly infected or affected by microbial organisms. Macrophages are cells which will engulf these pathogens and destroy them, loaded with IgA antibodies in the mucus and salivary glands and in the tears, help form some levels of defense for us for the respiratory system. But recognize in the respiratory system, most of the primary protection against invaders, against microorganisms, exist at the level of the upper respiratory system. Most of the mucus that lines the passageways, upper respiratory system. The pseudostratified, ciliated, columnar epithelial tissue, primarily in the upper portions of the respiratory system. These tall cells, columnar cells, with cilia on the top, have a mucus layer that's over the top, this mucociliary border that allows bacteria, when it comes into the system, to get trapped in the upper respiratory area, and then either by coughing or sneezing, we expectorate those microorganisms in that mucus layer. Now, sometimes we expectorate it, sometimes we swallow it. We swallow it, the digestive enzymes in our stomach will destroy the pathogen. But that's our primary mode of defense for upper respiratory invaders, upper respiratory microorganisms. Now, the problem lies when these organisms get deeper into the lungs. The further into the lungs you get, the cell type changes. Instead of having the tall columnar epithelium, by the time you get to the alveoli, all you have is this one thin layer of squamous epithelium. Why? Because in the alveoli, remember, oxygen and CO2 have to exchange. You need a very thin surface for that diffusion to take place from one concentration to another. And so big, tall, ciliated, columnar, pseudostratified columnar epithelium wouldn't work well as an exchange surface in the alveoli. So air, by the time it gets deep into the lungs, is essentially sterile, or certainly absence of bacteria. At least you would hope that it would be. Because if not, if significant bacterial loads gets into this type of tissue in the alveoli, where only you have a thin layer of squamous epithelium, then these infections can cause major problems. The bacteria will grow out of control. It's a warm, moist environment. Bacteria likes a warm, moist environment. It has an adequate amount of nutrient supplies because it only has one layer of epithelial tissue to irritate and destroy, probably cause a little localized bleeding. There's a significant amount of nutrients for bacteria in blood and in the tissue area. So these organisms will begin to grow out of control, and that's what in essence would lead to a pneumonia. Number of potential pathogenic organisms are a part of the normal flora, the normal microbiota in the upper respiratory system, and these organisms seldom cause disease. As you know, the normal flora, or the normal microbiota, is a part of our system, and we need that bacteria because it will compete with the invaders. They have the same nutrient requirements. The bad bacteria and the good bacteria all have the same nutrient requirements. We want the good bacteria to predominate, because if it competes with the same energy source, then the bad stuff won't grow. Now, in the lower respiratory system, again, we start to see a significant diminution in bacterial presence, and then eventually, frankly, at the level of the alveoli, the tissue is essentially sterile. Now, upper respiratory diseases cause symptoms of inflammation. Now, the inflammation can occur in the absence of bacteria. Pollen and other types of viral contaminants can cause inflammation in the absence of bacterial infection. But with bacterial infections, typically we will see some type of an inflammatory response. An increased growth of strep pyogenes in the back of the throat leads to strep pharyngitis or strep tonsillitis. The term itis refers to inflammation. Inflammation primarily in this case associated with microorganisms. Laryngitis, tonsillitis, sinusitis, all of which can lead to these inflammatory processes. Epiglottis or epiglottitis, inflammation in the little flap-like structure you see in the back of your throat. Now remember, that flap-like structure usually covers up the vocal cords or the glottis, and it is the tissue covering, the endothelial tissue cover, that gets the inflammation and will begin to swell. The true cartilaginous structure itself, the epiglottis, doesn't necessarily change in its shape, but the lining will swell up significantly, so much so that it can cause an airway obstruction. Organisms that lead to that are usually in the Haemophilus family, Haemophilus influenza, type B, or what's seen. Microbial diseases of the upper respiratory system, laryngitis, tonsillitis, sinusitis, epiglottitis, again, those are the most common organisms that are associated with these inflammatory conditions. This illustration just shows you the upper respiratory system, sinuses in the frontal sinus, maxillary sinus, sinuses in the middle of the ear. There's also sinus back here, the mastoid sinus. Infections can attack the nasal mucosa, chronic sinusitis, posterior oropharynx, where the nose and the mouth will communicate. And then infections, because they exist, they're a normal part of the flora, can be. We can see other structures inside the mouth, such as the tongue, epiglottis, larynx, and trachea, which can be infected by these microorganisms. Strep pharyngitis or strep throat, caused by strep pyogenes, group A beta hemolytic strep. Important cause of streptococcal pharyngitis. Diagnosis is usually made by utilizing a specific test that demonstrates agglutination. Remember, certain organisms will make platelets and blood cells clump together, so you use a specific agglutination test. Treatment typically responds easily to penicillin and erythromycin. Symptoms are of inflammation, fever. Complications can be related to tonsillitis and/or otitis media. Group A strep, pathogenicity enhanced by virulence factors. Virulence factors, something that makes it big and bad. Virulence factors such as streptokinase, which will lyse a clot. In other words, bacteria sometimes can be localized by the body itself. The body's defense system walls off these organisms, and so they can't spread. But in the case of group A strep, has streptokinase. Streptokinase dissolves the clots that typically would impede the spread of tissue. To a degree, streptococcus was used, or the streptokinase has been used in clinical settings, producing a powerful antithrombolytic, or a medicine that basically will lyse clots. Used a lot in people who have to, who come in with heart attacks, Heart attacks are where blood clots will block off coronary arteries. The blood vessel blocked off can't deliver blood to the heart tissue. Person will get ischemia, cardiac ischemia. Cardiac ischemia can lead to cardiac infarction if you don't open up the blood vessel. Streptokinase, inject that in the bloodstream, it travels around, it gets to the heart, and the streptokinase will then dissolve the clot in the coronary artery that's blocked off the artery. So we see it used, well, it had been used a lot. Now there are newer, better agents that are out there, so you don't see it used quite as much. Scarlet fever, strain of Streptococcus pyogenes. In this particular case, the organism secretes a toxin, an erythrogenic toxin that causes scarlet fever. Now, erythrogenic toxin meaning that it is going to primarily affect the red blood cells. The skin gets affected by the toxin and will turn a pinkish red as the fever occurs. The affected skin may also peel after the fact. This is a presentation of Streptococcus pharyngitis. Strep pyogenes, again, the infectious organism. Resistant to phagocytosis, that's not a good thing because that's the way the body fights off infection. Streptokinase, we see will lyse clots. Streptolysins are basically cytotoxic agents produced by strep. And again, you can diagnose it pretty rapidly now. They have rapid strep screens in pretty much every clinic setting. And basically, you can just swab and just from a reaction alone, seeing agglutination of cells, and make a direct determination of the disease. This is presentation of scarlet fever. Also can be seen as a pharyngitis. Erythrogenic toxins can be produced by the organism as well. Corneum bacterium diphtheria, it's a group positive stack non-spore-forming organisms, causes diphtheria. Dividing cells often form into a particular shape, a V or a Y shape figures. Many people can have this and not be symptomatic. There are vaccines that are available out there for treatment. But remember, an endotoxin can be produced, or an exotoxin in this case. This organism can be produced. Production is controlled by a gene that requires a lysogenous phage. It's carried into the bloodstream, interferes with protein synthesis in the cells or in the host cells. The membrane is composed of fibrin and or dead human cells. Now, where's the problem here? Well, this fibrin is typically sloughed off from the tissue in the airway. So infectious organism comes in, secretes a toxin, but it will kill this coating, the inner coating of tissue. And then what happens over time, the body gets rid of that coating, so it sloughs off. And it's thick, heavy, tenacious types of debris that's in the field, in the lung field, and the person coughs these up, and this will block off airways. And so the person coughs and coughs and coughs, and these hunks of tissue will come out. Necrotic tissue, and that's what has characterized the disease over time. Laboratory diagnosis may be made by bacterial isolation and selected differential media. Speaking of lab technicians, if I may digress, did you hear about the lottery, $321 million lottery that was won? It was won by a group of lab techs, like 7 lab techs. Always said that they would play the lottery together, and they've been playing for years. And they won the lottery, and they had a party. They won, and they didn't tell anybody, but they treated everybody to pizza the day after they won, because you didn't want to get lawyers and all this stuff. You know, you won all that money, you got problems. But they got lawyers, and they treated everybody to pizza, and then they announced it today or yesterday that they had won the 7 people spent $321 million. Oh yeah, like I would come to work the next day. Cutaneous diphtheria can also be caused as well, characteristic of skin lesions, fairly common in tropical countries. In the United States, we see areas of lower socioeconomic groups are affected most often. Corynebacterium diphtheria, gram-positive rods, diphtheria membrane, fibrin, dead sheets of tissue, again, that are sloughed off, prevented by a toxoid. Toxin, we talked about toxoids before, which can be administered as well to prevent the disease. Oh, this is a good picture. This is a little slough of tissue, the fibrin clot. This is small, though. Trust me when I tell you, like armloads of this tissue debris can come out, be coughed up. We had a guy in a clinic I worked in once, an older guy that had diphtheria, and he had diphtheria years before, and he came in respiratory distress, and when we intubated him, because he went down We intubated him, and as we were bagging him, the bag mass would suck up these big, huge debris of it was old skin. And he had underlying lung disease anyway, so over the course of time, he just didn't have the energy or the ability to be able to cough up these clots. And when I say a clot, I mean this is old dead tissue that's just kind of hanging around. And but you know, when you're using positive pressure, you're able to get up all kinds of stuff, and so we were able to get up these big chunks. And we sent it off, and we thought he had like eaten a shoe or something, because that's what it looks like, and it was diphtheria. So it does happen. Otitis media, many of you may already be familiar with otitis media. It's basically an infection in the inner ear, middle ear specifically. Symptoms can occur either due to inflammation and or pus formation against the eardrum. Multiple organisms can cause it. Remember, the posterior oropharynx communicates with the mouth. Posterior oropharynx communicates with the ears through the auditory tubes. So we have an internal auditory meatus and an external auditory meatus, and bacteria will just migrate up the tubes. Kids have shorter tubes. Bacteria doesn't have to migrate so far, so kids get a lot of ear infections. As you become adults, our head gets a little bit bigger. Our auditory tubes, our heads may get a lot bigger, but the tubes will get a little bit bigger, and so the bacteria can't grow all the way up before our immune system fights it off. We also, as we get older, will develop a lot of antibodies to different viruses that can cause otitis, different bacteria that can cause otitis, so we don't see it as much in adults as we do in kids. Vaccine has been directed to be able to treat this, a pneumococcal pneumonia vaccine, which lessens the incidence of otitis media. I haven't really seen that to be true. That's what's reported, but I haven't seen a decrease in the number of otitis by people vaccinated. Otitis media organisms, again, strep pneumonia, Haemophilus influenza, Catarrhus is also another organism, Pyogenes, and Staph aureus also seen. That's an eardrum that's bulging. That's what you look for when you look through an otoscope at an ear. Usually this ringed area here, this is somewhat injected. Injected means just the little blood vessels are dilated here. These are probably a little more prominent than what you typically see, which gives you an indication of infection or inflammation. But sometimes this can be blood red, beet red. And then you see this bulge. When you see this bulge, you know on the other side of this eardrum is a significant amount of pus fluid or inflammatory fluid that causes problems. Viral diseases of the upper respiratory tract, the common cold, caused by many viruses, classified as coronaviruses or rhinoviruses. There are more than 200 viruses that cause colds. Immunity have limited use. Immunity develops in isolated populations due to IgA antibodies. The immunities accumulate with age. Laryngitis, otitis media are common complications. Symptoms are typically alleviated, but there's no real cure for viral diseases. They have a number of antivirals that are out in wide production right now. The herpetic drugs are viruses that were once thought to be able to be used to be able to treat the flu viruses such as Famvir, acyclovir, but it wasn't found to decrease the occurrence of viral infections from the common cold. Tamiflu is another agent that's out there now as well, and that's getting a lot of press now because they're hoping Tamiflu will help control, if it occurs, will help control the outbreak of avian flu to humans. Whether that's true or not is yet to be tested, but there is a huge stockpiling now going on of Tamiflu. For the common cold, most common one is the rhinovirus, accounts for 50%. The rest is coronavirus, and then rhinovirus attaches at the nasal mucosa by a special receptor. In the lower respiratory tract, diseases that we primarily see are conditions such as bronchitis and bronchiolitis. Bronchial trees get inflamed, the smaller bronchial tubes get inflamed. Some organisms that we can see causing problems there would be pertussis or whooping cough. Ciliary action is basically blocked by the accumulation of masses of bacteria in the trachea bronchi. Eventually, a cytotoxin causes loss of ciliated cells. This is referred to as the catarrhal stage, which very much resembles a common cold. Then later on in the paroxysmal stage, which is characterized by attempts to clear the accumulation of coughing. And then in this organism, in the lower respiratory tract pertussis or whooping cough, the bacteria may be cultured out of the throat by a swab and or by a wire while the patient coughs, or you can induce the cough and obtain the specimen as well. Recovery usually results in good immunity. New acellular vaccine is also out there and that is produced. For lower respiratory infections, we see bacteria, virus, and fungus, which can cause these infections, bronchitis, bronchiolitis, and or pneumonia. We talked already about the ciliary escalator, which is the little cilia that's on the portions of the upper portion of the lower respiratory tract. The upper portion of the lower respiratory tract would be the main stem bronchus, right and left main stem bronchus, and maybe some of the bronchioles. So we still have ciliary and mucus secretions there that will offer a significant degree of protection. But as we get deeper into the lung tissue again, remember you drop to a thin layer of squamous epithelial cells. Bordetella tussis is a gram-negative coccobacillus. It has a capsule, has a cytotoxin, which will damage the cilia of the cells. Again, a vaccine can be used to treat it. 3 stages: the catarrhal stage, paroxysmal stage, and the convalescent stage. Catarrhal stage typified by common cold symptoms. Paroxysmal stage